Well, good afternoon and welcome to this latest webinar in our Clear Impact series, when we'll be sharing the learning of some of our latest Clear projects, very much from the lens of clinicians and managers who are at the centre of delivering them on behalf of their organisations. Today's webinar centres on one of our projects from our current Clear North Eastern Yorkshire programme, which aims to build workforce transformation capability across the region, while at the same time pushing forward service redesign to address some of the current challenges. Today, we'll be focusing on the Clear CAMHS project in Hull and East Riding, which sought to reduce waiting times and streamline care for children and young people. Please note the webinar will be recorded so we can share it with others who are not able to join at this time. So our speakers today are Nikki Titchener, Service Manager for Hull and East Riding CAMHS, Philip Cross, Senior Project Manager, and both are from Humber Teaching NHS Foundation Trust. And we have Juliet McGilligan, Project Lead from the Regional Programmes Workforce Training and Education Directorate in NHS England North Eastern Yorkshire region. We also have Claire Brewster from the National Clear Faculty at 33N, who will be co-hosting alongside myself, Caroline Thompson, also from the 33N team. So let's have a quick look at the agenda for today. We'll be starting with an overview of the National Clear programme and also giving some background to the North Eastern Yorkshire Capability Programme. You'll be hearing those details from Claire. Then we'll hear from Nikki, Philip and Juliet on the project's key findings, recommendations and projected impacts. Next, we'll be moving to give our speakers an opportunity to reflect on their experiences of the programme, including the challenges and the skills they've gained. And then finally, we'll be moving to the Q&A session. So please put your questions for the speakers in the chat throughout the webinar or raise your hand later in the session. That's all from me at the moment. I'll hand over to Claire.
Thanks, Caroline. Good afternoon, everyone, and thanks so much for joining us today to listen to the great work that we've been able to do in Hull. I'm just going to talk a little bit about the Clear National Programme for anybody that doesn't already know. And Clear stands for Clinically Led Workforce and Activity Redesign. And what we aim to do is just really to empower frontline clinicians at the heart of healthcare to innovate and design new models of care and workforce. And we have people who are actually working in the service and they will come and join us and we work together to look at their service and any challenges and improvements that we can make. Clear is hosted and delivered in partnership with East Lancs Hospital NHS Trust, and it was originally developed in partnership with Health Education England, but it's also sponsored by NHS England Regions and Systems. Just move on to the next slide, please. We have 4 stages in a Clear methodology approach, and they consist of clinical engagement, data interrogation, innovation and recommendations. And what we do within those 4 key stages is we look at qualitative information, quantitative information, then we review and look at understand key challenges and work with the frontline team to develop new models of care and workforce, and then we publish our recommendations in line with the Trust's strategies and priorities and with potential outcomes. We're also keen to look at lived experience as well as looking at impact and outcomes for patients and service users. The next slide, please. The Clear team comprises of more than 70 staff, which include NHS clinicians, education specialists and data analysis, and we're all united in our passion to improve services across the NHS. These are some of the key areas that we're really passionate about, involving care and workforce redesign, big data analysis. We have robust information governance, we provide education of staff, and we also help, hopefully, to support recruitment, retention, improve patient care and experience, to develop a community of practice within the NHS in that we can promote restoration, recovery, and also clinically and technology led. Just move on to the next slide. Within this programme that we're talking about today, it involved a 26-week programme, and the 4 stages that I spoke about earlier are kind of illustrated in this snake diagram here. So it starts at the top in the yellow, and that's the clinical engagement phase, and the team will talk about that in more detail shortly. But as you can see, it snakes round to 26 weeks, and the clinical engagement is then followed by data analysis. Then we look at innovation methods, and then we talk about recommendations, and usually a report and case study is produced. Within, you can just move on to the next slide. This is just a map just really to show the areas that we've covered, and the both in England, but also the areas that we've covered within the NHS priorities. And as you can see there, the map is slowly turning blue, but the areas that we've worked on are colour-coded within those regions of blue. So we've done a lot of projects in urgent and emergency care, critical care, mental health, primary care, ophthalmology, elective recovery, respiratory, and some bespoke projects as well. We've now completed over 60 projects, and more are underway in England across the priority areas. We have recommended more than £50 million worth of productivity savings within this work that we've done over the last few years. Move on to the next slide, please. So I'm now just going to give you an overview of the programme that we're doing in the North Eastern Yorkshire. And why CLEAR in the North Eastern Yorkshire region, really. This is one of the first projects that we've actually involved NHS England staff and workforce redesign staff, and they've actually come along the journey with us to work with sites. And why we wanted to do that really was just to try and help drive forward workforce transformation in areas where regional stakeholders identified a particular related challenge or opportunity. It was also to try and enable sharing, learning and scaling, and to provide evidence base for transformation region-wide, and to build capacity and capability within that region. We've been able to work really closely with the region from NHSE, and we've had 4 members of the team that have been working with us within the first 6 months of this project. And hopefully we've been able to develop a package of transformation North East Yorkshire wide, which include publication of case studies and evidence of impact to support the sharing, learning and scaling. We've been able to also deliver practical number of workforce transformation projects, and also methodology, and been able to train up staff within that team. Just move on to the next slide, please. The areas that we've been working with specifically within the North Eastern Yorkshire region are Calderdale and Huddersfield NHS Foundation Trust, and they've worked with us over the last 6 months looking at mental health in urgent and emergency care, and also we've worked with them looking at their SDEC, same day emergency care units in both medical, surgical and gynaecology. Within the Humber Teaching NHS Foundation Trust, we're here to listen about to the CAMHS team today, but we're also now working with the crisis team as well in mental health. And within the Sheffield Health and Social Care Trust, their first project was around eating disorders, and we're now working with their community enhanced recovery team within their mental health trust as well. Move on to the next slide. I'm now delighted to hand over to the delivery team, and they're going to share their experience and story around their CLEAR CAMHS project. So I'm just going to hand over to Juliet.
Yes, good afternoon, everybody. I'm Juliet. I'm one of the associates that worked in this project, and it was an absolute privilege and a great opportunity to be an associate with CLEAR. In terms of the background of this project, we started the project at the clinical engagement phase in August 23, but actually the whole year before, in August 22, discussions were held with the Humber and North Yorkshire Integrated Care Board, and the Humber Foundation Trust. Initial discussions were held in the autumn and then January. So there was a real collaborative preparation to get ready for the project. There were regular meetings, and CLEAR worked hard with Humber. There was an excellent dialogue to try and understand what the key issues were that this project could address. So on this slide, you'll see the background for the core CAMHS project of issues to try and explore through the project. Waiting times were longer than the national average, particularly from referral to assessment and assessment to treatment. And both teams were facing high did not attend rates, teams being Hull and East Riding. There was also a need to streamline processes, pathways, referrals, criteria and decision making. There was an awareness that there were more neurodiverse young people being referred into the services. Also, a family-centred approach was required, and the skill mix needed to address that. And also, while team spirit was strong, the service needed a shared identity. So these were discussions held with the clinical sponsorship team at a higher level with management and leadership. And then when we started the project, next slide, please. We began through clinical engagement to understand in more detail. But just to clarify, 3 key challenges for the project scope before we started the project. We examined and redesigned practices and processes across both teams. We hoped to improve efficiency of referrals and assessment into the core CAMHS part of the CAMHS service. And we wanted to understand demand and capacity across the 2 sites. So the scope of the project was discussed, worked through and identified between Humber Trust and CLIA. Next slide, please. So in terms of the first phase, the clinical engagement, you will have seen from the background and the clinical, the scope that we knew what we wanted to explore, but we began to interview members of staff from core CAMHS teams, from other teams within the CAMHS service and within the Humber Trust, with external partners, and also with young people and their representatives. We interviewed 42 people in total, a range of clinicians of all different backgrounds, all different levels, all different roles. So it's really good to get that range of perspectives. A key aspect was in working with the Humber Trust Youth Action Group, where we spoke to young people in that group. So we got young people's perspective about the CAMHS service as well. So we covered a lot of themes. And next slide, please. And from that first clinical engagement phase, 6 themes came out by people saying the similar things again and again. So repeated themes came through. So these are the 6 themes here you'll see on this slide that came through at that point. And you'll see quotes on the right-hand side of the slide that are examples of each theme. So the 6 themes were core CAMHS identity and offer needed clarifying. There was like a blur of how core CAMHS offer was different from other CAMHS services. There was a theme of estates not being fit for purpose. So in terms of what young people who were having mental health issues were coming in to get support, the rooms were deemed to be very clinical in some buildings. In other buildings, it just felt that there wasn't a safe space for staff. So it was about fit for purpose for staff and for young people and their families. The third theme was about ways of working between teams could be improved, because there were so many teams interfacing, where processes were different between different teams. There was an understanding that was something to explore further on in the project. The fourth key theme that came through was about alignment of strategic vision and leadership. There seemed to be different interpretations of purpose in different teams, and there was a feeling that leadership was needed to help people understand their CAMHS service and work together better. The fifth theme was about workforce resource needing improving, and as you remember from the background, it was picked out that working with families was an important aspect that Humber wanted to address. So it came through the clinical engagement as well, that working with families was key and we could do more better together. And the sixth theme was about the patient journey needing enhancing. So what's it like for children and young people and their families who are on long waiting lists? And if they were waiting and their mental health could often deteriorate and their mental health could become more complicated. So that patient journey was picked up through the clinical engagement phase as something to really improve on, and how we could do that together came out as the next phase came through. I'm now going to pass to my colleague Phil, who will tell you more.
Thanks, Juliet. So as Juliet mentioned, part of the engagement was actually trying to get some feedback and interaction from the young people, and the trust run something called the Humber Youth Action Group. So that's the sort of forum where young people can actually discuss issues around not only if they're in service, but if they've got an interest in the service. And these were some of the sort of insights that we got from those sessions. No one said to me at school or the person on the phone what CAMHS was and what was actually going on. And that's something that fed through as well, about sort of like just explaining to young people what they are going to experience, and even who are they talking to and who they might be speaking to next. It's just sort of giving that sort of upfront insight of the journey they might be going on, so that it reduces the anxiety. It makes it feel like it's for them, you know. Another one there below, it's not just CAMHS that's the issue, it's the services around it that are working together. So again, that's something that Juliet alluded to on the previous slide, that came from the clinicians, but also as well that the obviously the young people have interactions with school services, perhaps local authority social services and social care and that. So it's just that CAMHS are part of a system, and it's just ensuring that those partner organisations are actually all working to the same end, I suppose. So there's a third quote there, being bounced around many different things, being told something different about myself, and that was something that came through more than once. Just sort of speaking to different clinicians, different specialist clinicians, giving a slightly different diagnosis. They'll go from one approach to another. It's keeping it consistent, it's keeping it cohesive. And a fourth one there actually, about speaking over the phone. That feedback came through that they didn't feel like they could be open and honest speaking to somebody over the phone. It's a barrier, being over the phone. Is it the most appropriate contact mechanism? So that's another thing that sort of came through and has fed through into the work we've been doing about looking at appropriate contact mechanisms. So if we can go on to the next slide, please. So this is some data. So the next phase in the clear process, obviously after the clinical engagement, we start digging down into the data and trying to look at the numbers behind the service. And there's the high level numbers there for the period that we were looking at. So we're focused on a period of 1st of April 22 to the 31st of March 23. And that period was chosen because prior to that, there had been changes in the service and the way it was delivered. And that was sort of like a stable period that was reflective of the current situation. So if you look at the tables there, I mean, the service covers through two teams, two geographical areas. So you've got the Hull and the East Riding. So if you look at the left-hand table there, it's sort of got the numbers of breakdown between urgent and routine referrals, with Hull being in the orange and East Riding being in the blue. So as you can see from that table, there are more urgent referrals coming through from the Hull area compared to the East Riding. And that's probably reflective as well of the quite different geographies and demographics across both areas, where in the East Riding you've got quite a large rural area, mostly rural area, with some towns which do have problems, but it's largely rural area compared to Hull, which is a compact city with issues that can be attached to big city environments. So, which is probably reflected in the higher number of urgent referrals received from Hull. So the table on the left is just a breakdown of timeframes. So the top row is the overall referral to discharge periods in days. So Hull 150, East Riding 130. We're taking on board that there's probably a longer referral to discharge period for Hull because there's probably more complex cases in Hull. It's got it's got higher areas of deprivation than compared to the East Riding. In fact, the Hull local authority is ranked as 4th most deprived local authority in England. So, and the issues obviously that brings across as well. On that table on the right there, although you can't read the full headings or titles fully, the second row down is assessment treatment times. So if you work up from the bottom, it's actually assessment to referral for urgents, followed by referral to assessment for routines. If we can go on to the next slide, please. Thank you. Okay, so there's some more information. So we looked in as well about challenges within the service itself and about inappropriate referrals and DNAs. So when we talk about inappropriate referrals, I think that links into the one of the comments that Juliet mentioned earlier about, you know, the identity of the team and the fact that, you know, are they being referred to the right team for the right reason? And we took the inappropriate referrals. If they had 1 or 2 contacts, then it's quite possible that they were actually not appropriate for that team and they would refer on. That also links in as well to that insights from young people, comments about being bounced around services as well, trying to find the right place. So that was another thing about interlink between the core CAMHS team and other services, both within CAMHS and the wider system. So looking at DNAs as well, I mean, the numbers are there. The sort of quite yeah, they're quite high. I mean, there was some costings done based on obviously time and hourly rates for the appropriate clinicians involved. So it was costed out at 88,000 being the cost of inappropriate referrals. And the cost of lost contacts due to DNA is about £900,000. So it's not inconsiderable. So taking all that information, we pulled together everything together and we sort of looked at quick wins. If you just go on to the next slide, please. There's just some summary of the quick wins that are identified when you started looking at the data and the clinical feedback, you know, so, and from the young people as well. So I mean, offering personalised appointments, so that was reflected through the feedback from the young people in the service, and it's been an appropriate appointment for the person who has that appointment. Improved communication for children, young people and families, that seems to be very important for the young person, because they need to understand what they're being, if it's a whole new experience for so many people, and it's sort of understanding what's involved, and it's making sure that it's clearly laid out, and the options are explained as well. Text appointment reminders, manage DNAs through text appointment reminders. reinforcing the CAMHS offer, that links in, you know, to the identity thing, and making sure that, you know, the appropriate referrals are coming through to core CAMHS. So we've reduced that sort of delays and lagging people being seen and being bounced around services. On the bottom row, they identify and work closely with external stakeholders. So again, that's schools, local authorities. It's those other partner organisations that obviously, you know, children come into contact with, children and young people. Sorry. We've got ensuring consistency of data collected and recording, and that's just so that something we saw in the data there, that there were areas where the data perhaps could have been clearer, and so, you know, just so there's a fully understanding of the service and the performance and areas for improvement. Peer support workers, again, that came through the youth action group. It's those other forms of support and that young people could go to, you know, and making therapy rooms more friendly. Well, yes, that came through on the feedback and our site visits as well. And as Juliet says, some of them look very clinical and not very child friendly, I would say. So that's my section done. If I hand over to Nikki, she can elucidate on the next few slides.
So with all the work that we came up with and all the outcomes from each section that we'd done previously, the clinical engagement and the data collection, and what we did was we came up with a new model, and it doesn't look anything necessarily great and glorious or anything that possibly hasn't been done before, but it feels like it works for us. So what will happen is referrals will come in via our contact point system at the moment, because we weren't able to change that through this piece of work. So what we'll have is a little team of clinicians that will look at the referrals that come in and will prioritise the referrals. So they should, in theory, come in with a prioritisation on them from contact point, but unfortunately that's not always correct as per what we feel is right for that referral. If the referral is one that needs prioritising, that will be given a safety plan call within 72 hours, and that plan will be created with the family and the young person themselves to ensure that they have maximum safety. They will then be offered something called a choice appointment within that safety planning phone call. And those choice appointments are a slight move away from what we would traditionally call an assessment, because clinicians wanted to move away from assessment, calling things an assessment. So it's much more of a collaborative way of working with the family and the young person. And I say working with the family because it's really important that we maintain working with the family right from early doors, because it feels at the moment that what we have in the system at the minute is much more working with the individual rather than the young person and the family. And that came through very strongly, that we wanted to work with the family as early as possible, as well as the young person. So at this point, obviously, it may be that they've got everything that they need from working within that choice appointment, and it may be that they're discharged at this particular point. If the clinicians are unsure, they could take it to the MDT to discuss further actions, or they can go on to what we're adding in extra to what we have currently and starting work on family partnership collaboration appointments. So this is a series of 6 to 8 appointments that will be offered to the young person and the family. And these appointments will be offered with the same clinician that has done the choice appointments. So there will be a series of appointments that will be to engage more with the family and to get to know them get to know them more, and to really start to work with them and to really find out what's going on for them as a family, and to start to enhance their skills as a family as well. If after these appointments, it may be that that's all that they need again and again, it could be another point of discharge, or it may be that they need more. And this is the point where it could be that they need maybe additional therapy work. So it could be CBT, it could be EMDR, it could be that they need to see the psychiatrist and may need medication. So at this point, a therapist may be added in, but that same person that has been with them on the journey throughout, the key worker, would remain with them. And that's something that doesn't happen at the moment. So that young person and family would have a consistent person working with them all the way through. And that, from talking to the young people, seems to be a really important part of working with them, so they always have that consistent person. And that person, key worker, care coordinator, whatever we're going to call them when it comes to it, will be the person that is always in touch with them, that will go to any meetings that comes up, and will coordinate everything for them, and will also be in contact with their therapist, will be in contact with school, whoever that needs to be. So that's and again, obviously, when we go down the routine pathway, that will happen for them as exactly the same as well. So that's the new model of care that that has come out of all of the recommendations. If we can move on to the next slide, please. A lot of these recommendations are a little bit of what I've described already. So it's about streamlining, getting that first contact right, making sure that we have everything right from the beginning, making sure that we have given them a choice about face-to-face or virtual appointments. Obviously, we can offer a consultation as part of that model as well. And we're going to make sure that we have more effective working with contact point. As I've already mentioned, families are going to be integrated throughout the whole treatment process, and make sure that they're seen as part of the solution, and get that collaborative working going. Key work is going to be allocated all the way through, which will hopefully make that journey really smooth and make sure that the young people are not repeating their stories all of the time. What we really wanted to do was improve access. Obviously, Phil mentioned that obviously East Riding is a very rural area, and that makes it difficult for young people to have access to some clinics. So we were thinking about how we could get access for young people that are out there and not able to have transport, etc. So we've got the idea of having a mobile therapy bus. I have actually been able to action some of that already, and I've got processes in motion to get that up and running. So there's talks already in the process for that one. So that's quite exciting for us. Consolidating teams for Hull and East Riding. As we've mentioned, it's 2 teams. We were talking about the possibility of it being on one site. We have like 4 bases at the minute for 2 teams. What we think will happen now is it's going to be just consolidated down to 2 bases, rather than being onto one site. Just because of the logistics of everything, we don't think it's going to be possible to get one site, but it still be a lot better. But what will be important is that we have one set of processes across the 2 sites, and I think that's the one model will help us do that. So I think that's going to be really important. We decided that we would go for the fully embedded trauma-informed model, which will enable everybody to have those clear roles and responsibilities and that clear understanding of what we're working with. One of the other things that's going to help us do what we need to do with this new model is making admin efficiencies and having really clear timetable clinics and reducing documentation time for everybody, because at the moment the admin sometimes takes longer than the actual therapy, and we want that to be reduced. So we're going to have a new admin role, which is somebody that's going to be responsible for taking on booking in everybody's clinics, finding room bookings for everybody, and helping out when people are ringing up and saying, "Oh, sorry, I can't make that appointment." And also being responsible for ensuring that all of the that one of the quick wins that we mentioned was obviously the text messaging and everything, and all that goes out. We've actually had a trial run with that at the moment, just by admin making telephone calls to people. It's been a bit of a trial in the East Riding. So the admin have been making telephone calls to people a couple of days before their appointment, and we've actually had 100% success rate with that so far. So that's been working really well for us. So that's quite exciting. That's going to work for us. Number 6, the clearly defined autistic and neurodiverse pathways. I think this is going to be a longer term thing for us, because obviously there's a lot of commissioning that needs to go into this. It's something that we talk about a lot in terms of all the neurodiverse young people that come through to us as a core CAMHS team. We're going to have to upskill the core CAMHS team if that's something that's going to continue to happen. But also we're probably going to need additional funding going forward in the future as well, because it does take a lot more time for our clinicians to work with these young people because of the additional work that they need to put in. Next slide, please. So the cost savings, Phil already mentioned some of this already, but if we can, obviously it's not cost savings in terms of actual bodies as such, but it is a cost saving in terms of the time, etc., that we can put through, and in terms of so there is significant ones that we can make. So as I've said, we've already had a 100% success rate in the East Riding by trialling making the telephone calls. So that does make it better in terms of the speed that we can get through waiting lists, etc. So it will make an impact. And as you can see, there is significant figures there that we can do that with, and also in terms of hours that goes forward with that as well. Next slide, please. So in summary, it's going to provide us opportunity to develop our initiatives and improve things for children and young people across the whole of the patch for us, Hull and East Riding. We've already started to make those inroads in terms of improving DNA rates, and hopefully once we get onto our new system, because we're moving on to a new system from Lorenzo to System 1, we'll continue to make those and make those across the whole of the patch when we're getting those text reminders in and that's supported. We're also looking at an AI system as well, which we're going to be having further talks on, which will hopefully make improvements in terms of the amount of time that we spend on paperwork. We've got a meeting set up with Clear in a couple of weeks' time to take that forward as well. And also, consolidating both teams and working with that new model and working with families in a much more integrated way, I think is going to make a huge difference to both the team and families. And making those efficiencies across timetables and things is going to make a huge difference as well. So I'm now going to hand over to Claire for the final part. Thank you very much.
Thanks, Nikki, and thanks guys for a really detailed description of the project, and as you can see, it's has been really in depth, the work that the people have done up there in Hull and East Riding. We're now just going to spend 5-10 minutes on personal reflections for the team really, and want to ask you all about any challenges that you faced along the way doing a project like this, working in your own environment and looking at things that may be a bit of a challenge. So I was going to ask Nikki first if you can just describe some of the challenges that you faced along the way doing this project?
I think the main challenges for me really were obviously working within the service was sticking to the boundaries of making my clear days and not stepping into having to go back into the team and listening to emails or responding to phone calls and or working ridiculous hours, which I did at times. But that was one of the hardest things, and trusting that the person that was taking over my role was actually doing what they needed to do. So yeah, that was one of the hardest things, I guess, to do that. But yeah.
Okay,
I think,
thank you.
Yeah.
And Juliet, could I ask you the same question, please?
Yeah, sure. I had the same issue as Nikki, because I work for NHS England the other 3 days a week. But we got there. We learned how to protect that time. But another issue for me, a challenge that was for me, because I work at a regional level, was to understand how the Humber Trust worked and all the different teams and all the different services. And I'm not a mental health professional myself, so there was a lot to learn about mental health as well. I mean, I'm a parent and I've got relatives who've experienced mental health issues, but the understanding of what the service is from the inside. But I had a great team to work with, Nikki, Phil and Kate and the Clear team. So I learned from colleagues.
Thank you. Finally, Phil, could you describe any challenges that you faced along the way?
Similar to Nikki and Juliet around the balancing my normal role and this, the good thing about the approach is that the days were ring fenced to an extent that it wasn't just done in and amongst. But again, as both have described, it's just that things not cropping up during the clear days that are normal work related. It was good to have that ring fence time, but it was just been, and it's a bit of a mind switch as well. From Thursday to Friday, you're going like clear, back to normal job, sort of flick the switch. But yeah, I mean, like Juliet says, I mean, even though I work in the trust has 4 different divisions covering different diverse services, from mental health community teams to forensic services, children's LD, all the rest of it. And I've not worked that closely with the children's services in the past. It was good to get that deep dive into the core CAMHS service, but also as well, it was a learning experience to just understand the intricacies of what the service does deliver.
Yeah, thank you, Phil. And just finally, really, what are your key positive takeaways? I think especially in relation to growth and skills development from a personal point of view. What have you got out from doing the project? And I'll ask Juliet first.
So a key positive takeaway for me was that focus on the journey of young people, how to make the support and care they got as good as possible, as smooth as possible, and for them to understand it. My other 3 days of the week were working in terms of improving workforce training and education for people with learning disability and autistic people, where we try and get lived experience into our work to help us make good decisions. But the Clear project was excellent. It's like really trying to understand from clinicians, from people working the service, and from young people themselves, what could work to get those ideas and innovations through. So that was a really big piece of learning for me, and it's a great the focus, protecting the time to really focus on the challenge through the research model was excellent. Thanks, Claire.
Thanks, Juliet. Nikki, could I ask you about your positive takeaways?
Yeah, there's many, I have to say. Claire couldn't have come at a better time for me, really. I think I was probably at one of the lowest ebbs I've ever been at in terms of my career, in terms of my confidence. So for me, Claire has given me my confidence back. It's enabled me to do presentations, which I've never been able to do before, because I just didn't have the confidence. As you know, I was able to stand up and do that NHS England presentation, which I never thought would be possible for me. So yeah, it gave me that, but also it's given me the skills in terms of thinking about doing projects going forward as well, and thinking about things really differently, and just to think about things methodically, and just being able to really focus on the different elements, I think, of doing a project as well. I think that's been really important as well, to really think about what you need for a project, so that's been really important for me. But to work with the young people as well, and work with the team actually, and really get to grips with what their thoughts and feelings were, I think was really important. And I'm really looking forward to doing that, and taking this on and really doing the actual transformation work with them. So because we've got the project plan ready to go now, and it's gonna be great. I hope, taking it forward and really embedding it.
It's been really good to watch your journey, Nikki, from working in the service and seeing that you've been able to have that space and time to stand back and look at things, and, like you said, work with your colleagues and service users has been an amazing experience, I think, for us to watch as well. And your growth and development has just been, it's been great.
Thank you.
Phil, could I ask you as well, what personal takeaways you've got from doing this program?
No, absolutely. I've got a lot out of doing this piece of work. I mean, I'm a project manager as it is, but so many initiatives and also solutions seem to come from top down. And what's been really good about this is the time and energy that was actually put into speaking to people who do the job, which normally we don't get to do. You might do a stakeholder engagement session or two, but to actually take that as being the groundwork, and the foundation for the piece of work, to actually listen to what the clinicians have got to say about where they see problems are and where they see solutions are as well, because they know the day in, day out job. It's been brilliant for that point of view, so it's been good.
Thanks, thank you. I think now we're going to open the floor up for questions. I hope you've all enjoyed listening to the project team and the work that they've done with the CAMHS. So if anybody's got any questions, I'd be delighted to answer them.
Many thanks, Claire. Can I just ask very quickly, before we move to questions, if you would like to receive the slides from the session and more information on our webinars and series, please could you add your name and email address into the chat, because we'd very much like to be able to send this to you. Anyway, I think we've had a number of hands jump up. I think, Toby, you have the first hand up. What question do you have? Thanks very much, Caroline, and thank you, guys, for your presentation. It was absolutely fascinating to see, and really appreciate the time you've taken. I was also really fascinated by the amount of engagement with the service users, the young people, which I think is absolutely amazing. Something we normally have to tread very carefully with, but clearly we did on this project. And I would love to sort of clarify just how involved they were, not only up front, but also in sort of shaping the recommendations. Were they kind of engaged throughout the journey? So I'd just love to understand a bit more about that, because I think it's absolutely brilliant that's been done in any way, shape or form. But yeah, just wanted to understand that a bit more fully. We spoke with the young people right at the very beginning, within the clinical engagement, and so we heard their voice then. And then after we'd done the model, we went back to them and spoke to them about the model. And Juliet did a lovely, you said we did poster as well, which we sent out to them before we went to them with the new model. So they had that before we went to them. We went through it with them, and we presented the new model to them as well, and asked them what they thought of it. And they were, they took it on board, gave us their feedback. So we've added things in, taken things out from their opinions. Yeah. So we had 2 sessions with them. Yeah.
That's great. That's really great to hear. Thank you.
Thanks very much. And moving on to Lindsay.
Hi, Nikki. It was just a question for an update around the PS support worker action, because I'm involved in a kind of scoping across the patch, so Humber and North Yorkshire, and that's come out from children and young people across the patch. So an update on how you're kind of taking that forward would be good for me.
It's gone into the project plan, Lindsay. So as soon as we start, we've got to go to EMT on the 7th to make sure that we can definitely go ahead and start doing the piece of work. It is in the project plan. I've got a project plan meeting set up for the 22nd of May, and which hopefully will be the first way one of us taking everything forward. So from there, it'll be one of the actions that we will take forward.
I think I saw Colin's hand pop up then. Colin.
Yeah, hi, Nikki, and hi, Phil. Long time no see. Nikki, are we going to feed this into the emotional wellbeing and mental health access project that's going on in Hull and East Riding?
We can do, yeah.
Yeah, just so that it'd be good to get that whole system approach, I think.
Yeah.
Because we're working with around 29 other emotional wellbeing and mental health organisations from health, local authority, and VCSE. But yeah, great presentation, and thank you. Is there a timeline for the transformation?
Not as yet.
Okay, no worries. Thank you.
I think the recommendations, we have kind of put them in stages of 3 months, 6 months, 12 months. But you're going to EMT, like Nikki mentioned. We've already presented at the board, the ODG board, at the trust, and that was really well received and a lot of encouragement from the board. So that was a really positive outcome. And we do have a case study now as well. So if anybody's interested in the case study, that is available.
Yeah.
So we've actually put the case study in the chat as well, so the link to the case study is there. So our next question comes from Neil. Over to you, Neil.
Yeah, really, it's an aside, I guess, but some of that data was quite interesting, and I think I would like to sort of probably does follow on from what Colin was just saying about the Hull and East Riding mental health access project, but I think we really need to have a look at those routine referrals coming from East Riding and why there are so many of them that are getting through to core CAMHS, because that that it shouldn't be the case that there are that many more referrals in total from East Riding than in Hull. And in fact, I would have expected the other way around. I totally expect the higher number of urgent referrals in Hull. I think that's right. But with that huge number of routines, that makes a much greater demand, albeit perhaps less complex than Hull. But I guess there's something not quite right in the system there. So I'd really like to understand what's driving that.
Anybody else like to comment on that?
I think there's a big piece of work to do, Neil, around contact point, as you probably know. But obviously that wasn't within the scope of this. But yeah, there's a lot to do.
Thank you. Thanks very much, Nikki. Now moving on to Gail, who's also got a question for you.
I've actually got 2 questions, but one of them is based on one's a comment based on what Neil said. So that what Neil picked up about the East Riding, we are with Lindsay MacDonald, who's also on the call, and Karen Hilly, going to be doing some work with wider partners around how we reduce those inappropriate referrals. So not for now, but maybe we need to look behind some of that data and better understand where they're coming from, because we think anecdotally a lot of it's primary care who only have 10 minutes and just think mental health CAMHS. So we need to change the mindset of some of those referrers as well, so that instead of it coming to CAMHS and then going to the right place, it can go to the right place first time. So I'll pick that up with you, Nikki. My actual question was more you're off the hook, Nikki, don't panic. It was more for the Clear team, and we can pick the conversation up outside of here. But Humber were kind of a bit of a guinea pig and test because we hadn't had Clear in our ICB, but it would be interesting to have a conversation after this about the possibility of working with other CAMHS providers to build on the learning obviously you've done in Humber, but they may have, well, certainly I know some have similar challenges, shall we say, around the DNAs and the referrals. But it'd be really good thinking about how we reduce variation across our ICB. If we could maybe have a look at what capacity there is for Clear to work with other providers moving forward.
Yeah, that would be great. So yeah, we can pick that up, Gail. I'll be in touch.
Brilliant. But yeah, really good to see it. Great piece of work.
Thank you.
Lovely. I've just coming to the end, very close to 1:30. Just wonder, is there anybody else that would like to quickly stick in a question? I've been exhausting you. Can't see any more hands up. So so thank you very much. Very interesting piece of work, and it's really exciting to see some of the improvements that are already starting. So many thanks to all our speakers and for your time and your insights today, and to everyone who's attended. Please keep an eye out for details of our next Clear Impact webinar. Details will be on our website shortly and also promoted on our social media channels. If you have any questions at all about Clear, please contact the team. And thank you again for joining us.